Most people think if something were seriously wrong with their body, a doctor would catch it. You go in, you describe your symptoms, they run some tests, and you get an answer. That is how it is supposed to work. That is what we are all taught to believe, that the system exists to protect us, that the white coat means safety, that pain plus a doctor equals a diagnosis. But I have sat across from women who spent 7, 8, 10 years being told their pain was stress, their fatigue was depression, their joint swelling was just aging, their brain fog was anxiety, and all along, something very real was quietly destroying their body from the inside. Not dramatically, not with alarm bells, silently, systematically, in a way that only becomes visible once the damage is already done. Today I'm going to talk about one of the most misdiagnosed conditions I encounter in women. It is called mixed connective tissue disease. And the reason it gets missed for so long is not always incompetence. It is biology. It is pattern recognition failure at a systemic level. And it is a medical culture that was not built with the female body in mind. I want you to understand what that means before we go any further. Medical research for most of the 20th century was conducted almost exclusively on male subjects. The assumption was that male biology was the default, and female biology was simply a variation. That assumption has cost women decades of misdiagnosis, undertreated pain, and delayed care. It is only in recent years that the literature has begun to formally document what women have known for generations, that their symptoms are treated differently, that their pain is taken less seriously, that they are more likely to be sent home, told to rest, told to reduce stress, told to come back if it gets worse. Mixed connective tissue disease exists at the intersection of all of those failures. It is a disease that predominantly affects women. It presents subtly, it mimics other conditions, and it requires a level of clinical curiosity and specialist referral that the average rushed appointment simply does not provide. Mixed connective tissue disease, which we call MCTD in clinical practice, is what rheumatologists classify as an overlap syndrome. That term is important. It means MCTD does not behave like one clean, predictable disease with a single set of symptoms and a single confirmatory test. Instead, it borrows features from multiple autoimmune conditions simultaneously. From lupus, it may take the facial rash, the joint inflammation, the fatigue, and the blood abnormalities. From rheumatoid arthritis, it takes the swollen, painful joints. From polymyositis, it takes the muscle weakness. From scleroderma, it takes the skin thickening, the swallowing difficulties, and the extreme sensitivity to cold. Now imagine presenting to a general practitioner with a rotating combination of those symptoms over several years. One visit you have joint pain, another visit you have a rash, another visit you are exhausted beyond explanation, another visit your fingers are swollen and stiff every morning. The GP is not necessarily failing you. They are seeing fragments. They are treating fragments. What they are not doing, because the system does not incentivize it, is stepping back and asking what single underlying disease could explain all of these fragments at once. That is the diagnostic gap that MCTD falls into over and over again in women all over the world. Let me tell you what this disease is actually doing inside the body while it waits to be named. Connective tissue is not a single organ. It is the structural matrix of the entire body. It is the scaffolding inside your skin, your joints, your blood vessels, your lungs, your kidneys, your heart. It holds everything together. It gives your tissues their integrity and their resilience. In MCTD, the immune system loses the ability to distinguish between foreign invaders and the body's own connective tissue. It begins to attack itself, slowly, persistently, without ceasing. And because connective tissue is everywhere, the damage is everywhere. In the early stages, it presents as inflammation, joints that ache and swell, skin that changes texture, muscles that tire too quickly. But inflammation, left untreated for years, does not stay mild. It progresses, it scars, it hardens. And in MCTD specifically, the organ I worry most about is the lung. Pulmonary arterial hypertension, which is elevated blood pressure in the arteries feeding the lungs, is one of the most serious complications of MCTD. I have seen women arrive at our clinic with early pulmonary hypertension that had been developing quietly for years. years during which they were told their breathlessness was deconditioning, their fatigue was lifestyle. Their symptoms were not serious enough to investigate further. By the time we get to them, we are not preventing damage. We are managing damage that should never have been allowed to accumulate. So why does this keep happening? In my clinical experience, there are 3 distinct failure points that allow MCTD to go undiagnosed for so long in so many women. The first is the nature of the symptoms themselves. Fatigue, joint pain, brain fog, swelling, sensitivity to cold, difficulty swallowing. These are not symptoms that make a physician immediately think autoimmune overlap syndrome. They are symptoms that fit dozens of explanations, most of them far more common than MCTD. In a system built on probability, the rare diagnosis waits at the back of the line. The physician reaches for the common explanation first. Chronic fatigue, anxiety disorder, functional symptoms, perimenopause. These are not wrong diagnoses in isolation. But when they fail to explain the full picture and the patient keeps returning with new or worsening complaints, that is the moment the clinical thinking needs to expand. That expansion, in a 12-minute appointment with a full waiting room, is extraordinarily difficult to achieve. The second failure point is documented gender bias in medicine. I say documented because I want to be precise. This is not a theory. This is in the peer-reviewed literature. Women presenting to emergency departments with pain wait statistically longer to be seen than men with equivalent complaints. Women are more likely to have their pain attributed to psychological causes. Women are more likely to be prescribed anxiolytics or antidepressants when they present with medically unexplained symptoms rather than being referred for further investigation. For a disease like MCTD, where the symptoms are diffuse and the patient is almost always a woman between the ages of 15 and 50, this bias creates a dangerous filter. Her symptoms pass through that filter and come out the other side labeled as stress, labeled as anxiety, labeled as something she needs to manage rather than something medicine needs to explain. And so she goes home, again, still sick, still undiagnosed, still wondering in the darkest moments whether she is imagining all of it. The third failure point is the blood work itself, and this is the one that frustrates me most as a clinician because it is entirely correctable. The hallmark antibody for mixed connective tissue disease is called anti-U1RNP. High levels of this specific antibody, in the context of the right clinical picture, are essentially diagnostic. But here is the problem. Standard autoimmune screening panels in primary care do not routinely include anti-U1RNP testing. What they typically include is an ANA, an anti-nuclear antibody test, which is a broad screening tool. A positive ANA tells you that autoimmunity may be present. It tells you almost nothing about which specific autoimmune disease is involved. So a woman comes in, her ANA comes back positive or weakly positive. The physician notes it, tells her it is nonspecific and common in the general population, and monitors it. Nobody orders the anti-U1RNP. Nobody refers her to rheumatology. The door to diagnosis is right there. But without the right key, nobody opens it. I want to walk you through what the typical diagnostic journey looks like for a woman with MCTD, because I think it will be painfully familiar to many of you watching. She is in her 30s. She has been feeling off for about 2 years. She is tired in a way that sleep does not fix. Her fingers are stiff and puffy in the morning, better by midday. She has had 2 or 3 episodes of a butterfly-shaped redness across her cheeks that she attributed to rosacea. Sometimes her fingers turn white or blue in the cold, which she was told is Raynaud's phenomenon and is not serious. She has noticed some difficulty swallowing solid foods occasionally. She went to her GP, who checked her thyroid, her iron, her blood count, and her basic metabolic panel. Everything came back normal. She was told she was fine. She went back 6 months later because the fatigue had worsened. She was referred to a gastroenterologist for the swallowing. The gastroenterologist found mild esophageal dysmotility, offered some dietary advice, and discharged her. She saw a dermatologist for the rash, who treated it topically and did not connect it to her other symptoms. She saw an orthopedic specialist for a particularly bad episode of joint pain, who found no structural damage and suggested physiotherapy. She has now seen 4 specialists. None of them have spoken to each other. None of them have seen the whole picture. She is no closer to a diagnosis than the day she first walked into her GP's office. And she is starting to believe, because she has been implicitly told this enough times, that maybe it is all in her head. It is not in her head. It never was. And if that is you, or someone you love, I need you to hear that clearly. The average diagnostic delay for mixed connective tissue disease is between 5 and 7 years. That is not a reflection of how real or serious the disease is. That is a reflection of how poorly our system is designed to recognize it. Now, I want you to do something practical. If you are watching this and you recognize these symptoms in yourself, I want you to take out a piece of paper right now or open a notes app and start writing. Write down every symptom you have experienced, no matter how minor it seemed. Write down when it started. Write down whether it comes and goes or whether it is constant. Write down whether it is worse in the morning, worse in the cold, worse after physical activity. Write down every doctor you have seen and what they told you. Write down every test that was done and what the result was. This document is going to become your clinical case, because when you walk into a rheumatology appointment, which is where this diagnosis gets made, that documented history is your evidence. A rheumatologist who sees a woman walk in with 2 years of documented joint swelling, Raynaud's phenomenon, esophageal symptoms, a positive ANA, and a facial rash is going to think very differently about her than a woman who says she has been feeling unwell for a while. The paper turns your suffering into clinical data, and clinical data cannot be dismissed. The specific tests I want you to ask for by name are the following. Anti-U1 RNP antibody. This is the defining test and it must be explicitly requested. A comprehensive ANA panel with reflex testing to specific antibody subtypes including anti-Smith, anti-dsDNA, and anti-SCL70. A complete blood count because MCTD commonly causes mild anemia and low white cell or platelet counts. Inflammatory markers, specifically erythrocyte sedimentation rate and C-reactive protein, creatine kinase, to evaluate for muscle involvement. A pulmonary function test if you have any shortness of breath or reduced exercise tolerance, and an echocardiogram to screen for early pulmonary hypertension, which is the complication we most urgently need to catch early. You are not being difficult by asking for these tests. You are not overstepping. You are doing exactly what any informed patient has every right to do. And if a physician dismisses your request without explanation, that is the moment you ask for a referral to rheumatology directly. If MCTD is diagnosed, I want you to understand that this is a treatable disease. That word matters. Treatable. Not curable in the traditional sense because autoimmune diseases require long-term management, but very meaningfully treatable in the sense that the right treatment can control the inflammation, slow or prevent organ involvement, reduce flares, and allow a woman to live a full, functional, high-quality life. The cornerstone of treatment is typically hydroxychloroquine, an anti-malarial drug that has been used in autoimmune disease for decades and has an excellent long-term safety profile. During flares, low-dose corticosteroids are often added to rapidly dampen inflammation. In cases where there is significant organ involvement, particularly lung or kidney disease, immunosuppressant medications such as mycophenolate, mofetil, or azathioprine may be introduced. For Raynaud's phenomenon, calcium channel blockers can dramatically reduce the frequency and severity of episodes. For pulmonary arterial hypertension, there are now highly effective targeted therapies that have transformed outcomes for patients who are diagnosed before irreversible vascular remodeling occurs. The treatment landscape for MCTD is genuinely good. The problem is that you cannot treat a disease that has not been diagnosed. Every year of delayed diagnosis is a year of untreated inflammation, a year of accumulating damage, a year of a woman's life spent sick and unheard when she could have been treated and well. I want to close with something I think about often in clinical practice. When I look back at the women I have cared for with MCTD, I see two very different stories. The first story belongs to the woman who pushed, who went back to her GP a 5th time and said, "I need a referral to rheumatology, and I am not leaving without one," who printed out her symptom history and handed it across the desk, who drove to a different city to see a specialist because her local system had nothing left to offer her, who, when she finally sat in front of a rheumatologist and heard the words, mixed connective tissue disease, did not feel fear first. She felt relief, because she had known, somewhere beneath all the dismissal and all the self-doubt, that something was real. And finally, after years, someone in medicine agreed. She started treatment. Her inflammation came under control. Her fatigue lifted. Her joints stabilized. She got her life back. Not perfectly, not without ongoing management, but she got it back. And that matters beyond measure. The second story is harder to tell. It belongs to the woman who was told one too many times that she was fine, who started to believe it, because the alternative, that she was sick and nobody was helping her, was too exhausting to keep fighting for, who stopped pushing, who adapted her life smaller and smaller around her symptoms because no one was offering her a way out of them, who came to us eventually, but later, with lung involvement that had had years to develop, with inflammation that had had years to scar. Those are the cases that stay with me, not because we lacked the tools to help her earlier, but because the system failed to deploy them in time. And I carry that weight, as I think every physician should, because it is a preventable tragedy every single time. Your symptoms are real. I need you to hear that not as a platitude, but as a clinical statement from someone who has watched this disease go undetected for years in women who were telling the truth from the very first appointment. You are not anxious. You are not dramatic. You are not a difficult patient. You are a patient with a disease that medicine has historically been too rushed, too biased, and too narrowly focused to recognize. And you deserve better than what the system has offered you so far. Share this video with a woman in your life who has been dismissed, who has been bounced between specialists, who has been handed another prescription for anxiety medication when what she needed was a referral. Tell her to ask for the anti-U1 RNP antibody test by name. Tell her to request a rheumatology referral. Tell her to write everything down and walk in with evidence. Tell her that a diagnosis exists for what she is feeling. And tell her that once she has it, there is a real path forward. Because there is. And she has already waited long enough.